So they don't have a short PR interval and a slurred QRS. We're back to they have a QT issue. So we'll get locked back on repolarization for the next 15 minutes as to how I think we should do their diagnostic evaluation if you flag them. The conflicts persist, but I don't think they'll affect us. I'm going to detail the diagnostic evaluation for a patient that you flagged, and we'll critique a few of the diagnostic modalities and make sure we're well aware of their limitations. So I want us to really entertain 4 questions or considerations regarding the evaluation. First, like I already did 15 minutes ago, is it truly prolonged? Confirm the QTC. If it's lower than those cut points in the setting of a screening strategy, ignore them. Run from them. Don't call somebody 450 milliseconds long QT syndrome. Then, you don't like the QT number, it's beyond those cut points. Is it congenital or acquired? Third, what's the portal of entry? Is this a story-driven ECG or is this an incidentaloma? Completely different pretest probabilities. But then fourth, if there is an index of suspicion, have you sought and obtained genetic testing, and do you know how to interpret the genetic test result, just like do you know how to decode the QTC? Because both need to be interpreted, not read. So we'll start from the beginning. Is it prolonged? So remember, this is what I'm talking about in the context of screening to act on. 480 women, 470 men, and 460 before puberty. About a 10% positive predictive value that we've stumbled into a 1 in 2,000 disorder of long QT. So that's when we're going to start the evaluation if it's in the setting of a screen. We might start it much lower than those cut points if you did not like the story, and that's different. And then let's say regardless of how we got there, we don't like the QTC. Now we have to decide the root cause. Congenital versus acquired, and this is just to remind you, because I see this mistake happen too quickly just because we're becoming more aware of congenital, that we forget the huge laundry list of things that prolong your QT interval secondarily. So overall, acquired QT prolongation is going to be far, far more common than congenital long QT syndrome. That's going to be a true statement if you're 70. It might not be a true statement if you're 18 and it's an incidental finding when you are healthy. But you always have to pause when we flag that QTC in a screening program, because you may not know what's going on with them. What medicines are they on? Their screen could be flagged simply because they're in the midst of their 5-day course of Zithromax. And it has nothing to do with long QT syndrome. So have we checked the drugs? Hypokalemia and low magnesium are the 2 most common electrolyte disturbances, and the number of diseases from A to Z that prolong the QT interval as a byproduct of the disease is really a very large list, probably one of the largest differentials we have. So pheochromocytoma I've diagnosed after their screening ECG and so forth. What do you think that is relevant to our conversation of how many young people get to us represents the single greatest cause of QT prolongation? A normal vasovagal faint. The number 1 cause of transient QT prolongation is because their first ever ECG was obtained within 30 minutes to 10 hours of doing something called "I just fainted in the hot shower," that then caused them to go down the completely wrong trail of long QT syndrome. Anything that causes autonomic dysfunction will transiently perturb your QT interval. So if the context of that ECG was done in proximity of a vasovagal faint, don't run to long QT syndrome. Be very slow to come to that conclusion. Now, of course, we want to make sure we don't miss long QT syndrome, and so this entity is diagnosed based upon a scoring system, based upon a clearly positive genetic test, or idiopathically being above 500, and we can't blow off or blame away that ECG even in an asymptomatic host. And that brings us to the most important question, is what started this process? What is our patient's portal of entry? Is it story-driven or is it a screen? So this is then how I do it. It all should start with, what was your index of suspicion for the disease? You elicited something in his story or the family story and you've concluded it's high, you will do the entire drill. What's the drill? I'm not going to shame you by asking you the drill because it's really easy. ECG, Holter, treadmill, and genetic testing. That's the drill. Anytime you say, I have high index of suspicion for long QT syndrome, they deserve the entire drill. And what we're trying to do is convince ourselves and establish this diagnosis. Here's the point system. You get a lot of points for ECG findings, but not all 2 points or 1 points are the same values. They're not all equipotent. The story-driven points are going to be far stronger to compel the diagnosis than, look at how many points you now get by the score for being 480. 3 points. What did I tell you to do with 480 in an asymptomatic woman just a little bit ago? Does that equal long QT syndrome? No, it equals a 10% chance of long QT syndrome. And yet by the scoring system, this would give you the definition of intermediate probability of long QT syndrome, for which you and I need to decode what does that word intermediate mean. As long as you qualify that to say intermediate probability means a 10% chance. I don't think very many of us think of intermediate probability as being a 10% chance. That's pretty low. High probability is high. We jump from 10% going from 3 to 3.5, going from a 10% chance to about a 90% chance. So there's a huge jump that happens in this scoring system. Now, if you got to 3 by story, that 3 is a much stronger 3 than if I got to 3 just because I was 480 once and I am woman. So not all 3s are the same. The story is the most important. In fact, it's quing. I have to tell you, pause a little bit on why I now call it quing, is I got written up because I called it the story is king. And they said, oh, that's so you have to go to that attitude course. Because all I was trying to say is the story is the most important. So then the next talk I gave, I said, the story is queen, thinking that now I'm really hip. And then I got written up by the men. So I'm just deciding to go transgender and going queen. So whatever is most important to you in terms of the word, that's what the story is. And we can't state that enough because when we get the incidentaloma chain reaction, we don't have to necessarily call them. And the story that I'm talking about is you and I as detectives when we're assessing the faint or the spell, because most of our patients don't come to us with a loop recorder in. So when we hear about a faint, what we have to be concluding is, in our mind, are we envisioning a normal sinus rhythm-mediated faint, or are we envisioning a torsodogenic faint or an arrhythmic faint? And based upon that conclusion of that spell, we will either blow it off or we will really aggressively do the drill. So we just have to be much better phenotypers in assessing the spells. Now, the rest of the time I'm going to talk about it's not story-driven. It's called the screening ECG in your public school system or whatever for whatever reason. So there's low index of suspicion a priori. If the QTC in that setting is below those thresholds, get them out of there. Dismiss them. Don't call somebody who's 450 borderline QT prolongation, because they will too quickly go to Google and translate borderline QT prolongation to what? Possible long QT syndrome. And once you've done that translation, you have created a death trap. So it's better off blowing those off and dismissing. And on the other hand, if they are above those thresholds, then they deserve a drill. The best immediate drill to do is ask the question, is that a one of ECG or does it reproduce itself? The second best thing to do is snap an ECG, if possible, on that person's mother and father. That is worth gold in the evaluation of long QT syndrome. Because if this exercise here brings you below those thresholds, get them out of there. They're dismissed. On the other hand, if that follow-up ECG persists across the cut point, or mom or dad's ECG is above their respective threshold, now commence the drill. Because although it started incidentally, we're moving towards the chance that we have incidentally caught somebody with a 1 in 2,000, potentially life-threatening, but highly treatable disorder. In other words, it's all about the context. The general population, the chance of having long QT before their ECG is 1 in 2,000, maybe 1 in 1,000 if we've underestimated the true incidence of long QT syndrome. You are 440 and you're a 4-day-old infant, it's less than a 1% chance. You are 440 and you're a woman, called borderline by guidelines, not the woman, but the ECG finding, is called borderline by guidelines, it's less than a 0.1% chance. Now what if she is 480? The average QTC of all of my long QT mutation positive subjects. For them, that might be the average. For her, it's only a 4% chance. Now what if you are 440 and you are now the child of a mother with irrefutable long QT syndrome? Well, it doesn't matter that you're 440. It's a 50-50 chance that you inherited mother's mutation. And then, of course, if you sunk while swimming with your loop recorder capturing torsades and upon surfacing your QTC is 500, yep, that's long QT syndrome. Okay? So it really depends on the setup. And then finally, if we commence that drill must include genetic testing, because we can make the diagnosis of long QT syndrome based solely on the genetic test coming back positive. The guidelines are quite clear 6 years ago and still now as of last week's AHA statement. If you and I in this room are going to call somebody long QT syndrome, genetic testing is a class 1 recommendation. If we're not ready to call them long QT syndrome, but I don't know why they're above 500 in adulthood or above 480 and they're asymptomatic, meaning they are idiopathic QT prolongation, that idiopathic individual deserves long QT syndrome genetic testing as a class 1 indication. It becomes class 2 at lower thresholds, but as you start to do the genetic test at lower cut points, the noise in the genetic test system will start to bite you. And then family members, of course, must have the genetic test to rule out the presence of the disease when it's been established. You can do all of the long QT genes, for which there's now 17 and counting, or one could do genetic testing of the 3 major long QT genotypes. But like with any diagnostic modality, this is not perfect. The Eindhoven 100-plus year ECG remains imperfect, as you heard, and so does the newest test. In other words, what's the biggest issue in genetic testing now is the maybe result. Now, the test doesn't get stamped with maybe. Instead, oftentimes the genetic test will come back to you and me with words like possible deleterious mutation identified. That's really annoying, isn't it? Which is it, possible or deleterious? Okay, and then the genetic jargon swear word of vulgarity that matches borderline QT prolongation is the variant of uncertain significance phenomenon. And so we have to realize that genetic testing is not binary any more than a QTC above or below 480 being somehow a binary threshold. There's ambiguity in the system. I've coined the phrase for the VUS issue as a place called genetic purgatory, because if you know anything about purgatory, you sure as heck don't want to get there, and you have no clue how to get out of there. And that's the issue that we face with genetic testing, and so you have to navigate through a genetic test very carefully. So let me leave you with a couple of take-home points for this segment. In the absence of a story, who cares about 450? Forget about it, dismiss. Second, acquired QT prolongation is far greater than congenital long QT. Don't forget to ask about what medicines they're on and so forth. Is that athlete anorexic? Well, that's probably their QT issue and so forth. Third, story is really important. Be a detective. And then be a wise user of genetic tests and a wiser interpreter of its results. Reports must be interpreted. Just like we should not be practicing literacy with the ECG, right? Literacy being, could I read what the GE Marquette systems say across the top of the screen? We should not be satisfied with practicing literacy with our genetic test reports, meaning, could I read the 4 pages that the company sent me? We have to decode the results ourselves. Thanks a lot.